Thank you, Baba, for your great coordination. My name is Anjom from Cambodia. I'm the star advisor to the National TB program. Currently, I support the National TB program to implement the third National TB Prevalence Survey in Cambodia. Next slide, please. This is the outline of our presentation. I will talk about the background and brief information about the prevalence survey in Cambodia and program planning, and then we go to the main topic about setting up of a Delft unit in the field and the connectivity and the use of computer detection in TB prevalence survey, and finally we talk about challenges. Next slide, please. Here's the background. Next, please. Cambodia is one of the countries in South Asian region, and we have around 17 million population. Based on the WHO, our estimate TB burden in 2021 is about 288 per 100,000 population, and the estimate incident TB among HIV is about 5 per 100,000 population, and MDR TB is about 6.2, and the TB mortality among HIV negative is 21 per 100,000 population, and TB mortality among HIV positive is about 3.4 per 100,000 population. In the right-hand side, you can see the trend of TB in Cambodia. TB incident, new and relapse TB cases notified TB incident among HIV positive from 2021. You can see overall TB incident in Cambodia is going down. And the new and relapse TB cases a little bit fluctuate, but in the past few years it's going down as well. Next slide, please. Here's the TB case notification in 2021. And for the total new and relapse TB case notified in 2021 was 21,000 and around 21,600, and around about 80% known their HIV status, and the proportion of pulmonary TB is 59%, and bacteriologically confirmed among pulmonary TB is 60%, and the TB among children is high in our country, is up to 23%. Which is higher than global average. And you can see a proportion of women aged 15 years old and over is 32%, and 45% for men aged 15 years old and over. So in total, TB case notified in 2021 is 21,660. Next slide, please. Cambodia already conducted a two-time national TB prevalence survey, and this time is the third one. And you can see this bar chart is the prevalence of smear-positive pulmonary TB in Cambodia among those aged 15 years old and over. Overall, between 2002 and 2011, there was 43% reduction for TB prevalence. But what we note here is the reduction among those with chronic cough. If you can see here, in 2002, the prevalence of smear positive among chronic cough is 274. And then it reduced to only 116. So there was a 58% reduction. But among no chronic cough, the reduction is a little bit lower. It's only 70% of reduction. Next slide, please. And this the TB case notification in Southeast and Asian country. You can see here, this the case from 2005 to 2018. Overall, in 2005, under universal health coverage, most of country reached the target of notify TB case about 70%, and the case detection and cure rate about 85%. And we expect that this trend should be continue to decline. But after that, you can see under stop TB, overall TB case in from 2006 to let's say 2015, it seems like it's not really a significant reduction. And after that, you see in some countries there's some reduction of TB case notification, but some countries still increase. And you can see the yellow one, the yellow line is Cambodia. You see the TB case notification is declined significantly, and the other countries continue to increase. So this you can the prevalence survey will tell us, is it the real reduction or not. Let's see after the prevalence survey that we are now conducting. Next slide, please. There are some differences between the first and second survey and the third TB prevalence survey. In the first and the second TB prevalence survey, we use paper-based for data collection with conventional chest X-ray, while our current third national TB prevalence survey is more like use technology. So we use digital chest X-ray that we are discussing here. And also we do expert ultra and with AMGIN. And for screening, we screening chronic cough and any abnormality of chest X-ray. We'll also send to for sputum collection. Also diagnosis based on smear and solid culture. And for the current survey, we use electronic data management. We use RedCap, and we still keeping like basic screening, chronic cough, and abnormality of chest X-ray in order to compare the current survey and the first and second survey. So we can say technology will add the value to this survey. Next slide, please. The brief introduction of the third TB prevalence survey that we are currently conducting. It is a cross-sectional population-based survey with multi-state cluster sampling. So it was a 3-state cluster sampling. So we select the OD across the country. In total, we have 103 OD districts. After that, we select the commune, and then the final cluster is village. So the whole country survey, and we stratify our cluster in 3 group: rural area, urban but not Phnom Penh. Phnom Penh is the city, the main capital of Cambodia, and Phnom Penh. So these are the 3 strata in our survey. So we include all persons who are 18 years old, 15 years old and over at the time of the survey, and reside in the selected cluster at least 2 weeks. And for those who living in the military or diplomatic compound or hospital and hotel will be excluded from our study. Next slide, please. This is the overall process of the national survey. So you can see the upper left side is the arrival of participant. And then participant will receive informed consent. After that, they will go to measurement like blood pressure measurement, weight measurement, height measurement, and then go to interview that we use RedCap, the electronic data management system. After that, all of them will go to check X-ray unless there are some communication. And if interview we found a chronic cough or chest X-ray found abnormality, sputum collection will be request. We will collect sputum, and then if the sputum is at least one sputum is positive, further sputum will be collected for culture. And then the X-ray will be sent to a central team for verification and quality control. Next slide, please. This is our algorithm. So I already briefed a little bit earlier. We skin symptom and check X-ray for all participants. And then if symptom positive or check X-ray suggestive TB, then sputum collection will be performed. So check X-ray abnormalities that suggestive TB based on human reader or based on computer detection score. Our technical team decided to use the cutoff point of 50. So check X-ray with a cut score of 50 or over will be automatically sent for sputum collection. And this collected sputum will send to expert ultra. And then if any TBK, mycobacterium detection by expert for the sputum will be collected for both AMJIT and solid culture. Also, clinician there, they have the right to clinically diagnose of TB. If the cases suggest active TB, regardless of expert result, culture also will be done, and patient will be put under treatment. Next slide, please. So this is the concept of using CAD4TB in our survey. So we still keep the role of human reader because this they play very important role, and this is the same as the previous survey. And human reader read every X-ray immediately, and we expect that it's abnormal. We expect to screen positive around 10% or less, based on our experience. And as I said earlier, CAD4TB will help to prevent any error from human reading. And 50 is a threshold, the cutoff point for CAD score TB, CAD score that we designed for sputum collection. In addition, in order to ensure the quality, central reading will also be performed. And we also have external reading in order to ensure the quality of X-ray. Next slide, please. I will hand over from this slide onward to my colleague, Dr. Kema. Kema, the floor is yours. Thank you.
Thank you, Dr. Yong. Good morning, good afternoon, good evening, everyone. So my name is Kema. I'm from RIT Jakarta. So we are working together with the Cambodia team for the third national prevalence survey. So I will continue the presentation. So for the program planning, we have the training and the threshold selection. So 5 Delft units and 4 CAD4TB boxes were supported by USAID. And those 5 Delft units were distributed to 5 referral hospitals in 5 audits. And when we start the prevalence survey, those units were mobilized to be used in the prevalence survey. Next slide, please. So for the Delft online training for installation, our CAD4TB was conducted in April 2023 with the 22 participants, mainly technical coding and our end user like X-rating and data team. For the threshold selection with the CAD4TB score, it was conducted using the X-ray images from the ATIS case finding activities, around 4,000 images. And also we have the features in our Delft light in one ACF site, so around 240 images. So initially, we set the CAD4TB threshold for sputum collection with GenExpert 50 and above. And then we plan to have the reassessment of the threshold score using our real survey data. Next slide, please. So this is the threshold selection by doing reanalysis of ACD images by CATA. So CATA is one of the implementing partners of CNAP. They have the ATIS case finding activity. So around 4,000 images were blindly selected out of 16,000 ACD images, and all 107 GenExpert positive cases were included from last 1 year. And then there are X-ray screening results by CATA human readers. So the CATA team used the ODI unit, so their image quality is not very good. So those X-ray images were reassessed by the central readers of the previous survey. So according to the result, we initially set up the CAD4TB score at 50 with sensitivity 80% and 1 minus specificity 6.5%. Next slide, please. So observation from the threshold selection exercise. So in CAD score 60 and above, most TB are detectable, and this will be the reasonable cutoff for screening using ACD and triage, like when resources are limited. For CAD 50, abnormality is significant, but we cannot really say this is active, whether or not active or back confound or not. So that's why it will be text fusion in TB prevalence survey. For CAD less than 50, more non-significant abnormality, or sometime when the score becomes lower, normal by the human reader is observed. But however, we still have some back confound cases with the chronic or minimal lesions by chest X-ray. And we also observe some expert positive cases in and around CAD score 30. So mostly chest X-ray show the significant abnormality like atypical TB, lower lobe congestion. So these could be saved by human reader in our prevalence survey. So that's why we decided to set up 50 instead of initial setup of score 60 for the sputum collection. So whatever the reader decides, the CAD score 50 or more will be automatically sent for sputum for GenExpert Ultra. And we expect that human reader will save significant abnormality of non-typical TB disease among CAD score less than 50. So training to avoid too much overreading is essential to learn abnormal or normal. And then we will review the upcoming data to reassess the threshold score. Next slide, please. So this is the bringing and setting up of Delft light units to the field. Next slide, please. So according to our team, it's really portable and easy to set up. And on a fully charged battery, they can easily do 200 exposure, sometimes up to 250 exposure. And the operation hours for both Delft light system and CAD4TB is up to 16 hours with no problem. Next slide, please. So our typical cluster operation is around 1 week with total screening 3 days per cluster. So we have around 150 to 200 participants per day. So up to data from June 2023, we have around 99% of participants taking chest X-ray. Next slide, please. So this is the connectivity of Delft light units and CAD4TB. So the photo is from the real survey site. You can see the complicated cables and so many devices. Next, please. So connectivity with the Delft light. So the team decided to use the Wi-Fi option to connect the CAD4TB with the console computer because the cable connection sometimes create challenges with the data burner connection. So because when we use the data burner using the Bluetooth wireless connection, it shows some errors and image acquisition problems. So the LAN connection is given priority to the data panel, and we use the Wi-Fi for CAD4TB box, and we use the offline CAD4TB box system. Next slide, please. So we will talk about use of CAD in the prevalence survey. So from the reader perspective, the quality of X-ray images is very good, and CAD4TB system is really user-friendly, and then time to get CAD score fast. And then having CAD score and as well as the heat map help the reader not to miss the significant cases. Next slide, please. So this is our prevalence survey data up to June 2023. So we have 2 pilot site and 7 cluster data. A total of 3,303 participants were contacted for chest X-ray. So according to the CAD score that we set up 50 and above, eligible for sputum collection for expert ultra is around 75, is 2%. And then from the reader decision, eligible for sputum collection by expert is around 213, 6%. So out of those, we have total 26 expert positive cases. Next, please. So this slide is to show the CAD4TB score among all participants and also the human reader eligible participant. So you can see the CAD score less than 50 was saved by the human reader decision. Next slide, please. So this is the CAD score among human reader eligible and the expert positive cases. So these you can see around 20, 30, 40. Some of the expert positive cases, those were saved by our human readers. Next slide, please. So according to the result from those pilot and 7 cluster, now we are considering to lower our CAD cutoff score to 30 for gene expert sputum collection. And when the score is less than 30, we will still keep the human reader decision for consistency with the first and second prevalence survey. Next, please. So this is the example, like chest X-ray image of the first gene expert positive patient by that survey. So CAD score is 30, but human reader decision positive. So this is saved by the human reader for atypical, like lower lobe congestion. Next, please. So we will talk about the challenges. Next, please. So overall challenges are mainly the technical issue. So the team experienced frequent connectivity issues, like connectivity with the data panel. So when, as I mentioned earlier, when we use the data panel connection, wireless data panel connection is slow and sometimes image acquisition errors. And sometimes we have problem with the connection with the console and the CAD4TB box. So the team try everything. So sometimes they put SIM card with the data package and it works again. And sometimes without SIM, it works again. So each time the issue is different. And then the same thing, since the Delft light is fully battery operated, so sometimes we cannot use one, but the battery is charged, so no direct AC. And then for CAD4TB box, so once the image is sent to the CAD4TB box, we cannot delete. So sometimes we have the text images and error images, so we cannot delete by ourselves. We have to contact to the help desk to delete those images. And also, backup for CAD4TB box, we cannot do by ourselves using the setting. We need to contact to the help desk. As Dr. Young mentioned, for the X-ray, we need to send DICOM images for central reading and then external quality assurance. So those images need to download. So when downloaded, the naming protocol from CAD4TB box is not by the patient ID, participant ID. So we need to use specific DICOM viewer because those were done by the data people. So they need to use the DICOM viewer to sort by ID and find duplicates and such kind of thing. And also, sometimes we face there's a time difference with the help desk. So whatever issue, technical issue occur at the field site in the morning, so we cannot get the timely support from the help desk. So we think that it will help if we have the gantry support staff, and also it will help with the language barrier. Next slide, please. And challenges from the technician perspective. So they said that the adjustment of the X-ray generator up and down with the participant position is quite challenging. Sometimes they need 2 people to move up and down. And also for the Delft light, since this is not the routine activity and this is the study, we cannot use the portable detector panel hanger. We need to have the fixed one. And also the detector panel battery, we can only use maximum 50 participants because in the prevalence survey, sometimes we have to put the standby mode and then the team set is only maximum 50% participant and they need to charge the battery. And also like Cambodia, tropical country, sometimes in hot weather, we have problem with the connectivity with the detector panel. We thought it's the problem of the connector. Sometimes it's very hot and create the connectivity issues. And also for the system, switching from standby to active mode takes sometimes. So they need to wait. I think this is my last slide. Next slide, please. Oh yes. So we would like to thank our prevalence survey participant, our generous donor, USA, DFAT, Global Fund, and our implementers, CNET, WHO, RIT, JATA, IPC, CATA, and HSD. And thank you, everyone.